see him up yet.
He is online. Yep. You can go ahead.
There he is. Okay. Good morning, everyone, and welcome to the Finger Lakes Regional REMAC meeting. Today's date is September 15th, 2020. 6 months into our worldwide pandemic, it seems like a lot of people are setting back their fears and concerns, and I would like to remind you all that COVID is still amongst us. And I've seen crews wearing minimal PPE and in some cases not wearing PPE at all. And please remind your crews that this is by no means done with. In fact, I unfortunately still believe and hope I'm wrong that we may still be seeing the worst to come in the Finger Lakes region. And I don't mean to be a pessimist, but I think we all need to be realistic about this. So please do not let your guard down and pass the word out. I'd like to get the meeting started if we might we don't have minutes available, but I guess we'll just move right into standing reports then. Program Agency Coordinator.
So we're back in the office now. Things are starting to return back to somewhat normal. Still working on buttoning up some projects and getting some training CME stuff started back up, and beginning the process on what a conference might look like after the new year here. So we're suspecting it'll probably be a virtual in nature, but have to plan for both at this point. So what we're hoping to do is have our committee and or the folks from REMAC all come up with some topics and maybe a subject matter speaker, and so we can present a handful of different lectures and that type of thing. And that's all I have for now, Jack. Yeah. Jack, you froze.
Can you hear me now?
Yep.
All right. I think with February coming very quickly, I think we need to have those virtual plans in place. Donna, FLCC Program Director.
Paramedic program, the kids are back for their last semester. Obviously, those that got done in May and June have all tested. We only lost one student. He failed on both tries, so he's got to go back to a refresher. But Jake has 11 that came back. A couple went out because of grades, and a couple went out because they did not feel that they got enough out of the virtual classes from March on. So they're, I guess, coming back in January, we talked about. So with that, the other part of it is with council classes. We will register the last one this Sunday, which is the AEMT class. This is probably, if they all show, been the best turnout for the AEMT in the last 3 or 4 years, because I'm looking at possibly a dozen students coming to that, which will be great, I think. This EMT here is going, the one in Ontario ambulance is going, and the one in Cheshire Fire Department is going. So we didn't have any luck with the CFR, but I wasn't shocked at that or anything. The state is now allowing us to do the CFR refresher in amongst the EMT refresher, so we advertised it out, but had no takers. We don't have a lot of CFRs in our region, but with the state giving them a year extension, I think probably they won't cry wolf until next year.
Donna, since you brought up AEMT level, I've got some concerns. If you recall, at a recent state meeting, there was a vote on whether or not to follow the DOT or not. And much to my dismay, the vote was to do so, which would take away intubation privileges from the AEMT level. There's a discussion going around amongst all the regions right now showing concern for that, despite the fact that the majority of the REMAC or CMAC members voted to go with the nationwide protocols. What are your thoughts about how that would affect our current AEMTs and our new AEMTs going forward, and what are our options?
Well, because it never got to vote at CMAC, the thing was that they had approved it in May, but it was supposed to have been voted on at the September state meeting, and that never came to fruition, that it was ever brought up from what I can find, in that. So the curriculum still stands as it is. We will teach the intubation to the students in that, because the test will reflect that. They haven't changed the exams that I know of for anything. The thing with that is, and I can be devil's advocate on both ways. To take the intubation out, they still would be leaving the supraglottics and that in. And for the amount of intubations that are actually done in the region or statewide, or however you want to look at it, are dwindling, obviously, because CPAP took care of a lot of the respiratory part, or I won't say a lot of it, but some of it. And so looking at how many intubations the paramedics are getting, I'm not sure the AEMTs, even though they're taught it, are going to get that number of actual intubations. So with that being said, I can go either way. It's still in the curriculum. We're still going to teach it starting next week, because we have received nothing from the state that says no. So that would be basically the only thing. My biggest angst, and you and I have talked about this before, is I really found it difficult to think that they would not give the AEMTs the ability to give Benadryl, which I thought was kind of silly in that aspect of it for an anaphylaxis. But intubation wise, I could go either way, Jack. I don't know. It's always a nice pair of hands to have. If you have an AEMT in with a paramedic, obviously it makes it a little bit easier, or can make it easier. They at least know what's going on. Could they, take the intubation if the paramedic missed it? Certainly. Both of them obviously can use supraglottic airways. So I guess it really is, going to be the state's call and the physicians here's call as to whether, what we do with it. As long as we are leaving it in there, I'm trying to get OR time for the students so that they at least can see airway, vocal cords and everything. Obviously, if we go to just supraglottic, if the state changes it, that OR phase could go away, because there's really at that point not much sense of taking them into the OR for something that they can't do.
So my guess is it will come back up eventually at the state level.
I think so.
Right. And after the response from medical standards and CMAC physicians at the meeting that was discussed, they clearly had an overwhelming majority of physicians that did not want that level of intubating. So I think we need to discuss it regionally, because we still have the option, because I believe the wording says if they are so trained and allowed, they could continue to do it region by region, but that's something that this region would have to discuss and talk about.
Jack, hold on 1 minute. Who joined recently via phone? Just trying to get an answer.
John, I'm on by phone until I can get to my video.
Okay, are you the 3268?
I have no idea. I'm the one that's speaking right now.
Well, you're showing up.
I'll be home in about 5 minutes and can switch to video, but I'm just driving just now.
Okay.
John, I believe that's Krista from Thompson.
Okay, thank you.
Sorry, I was muted. It's Krista.
Thank you, Krista. All right, Dr. Davidoff,
Sure.
go right ahead.
Well, I think we need to have a discussion about the region's feelings towards AEMTs providing intubation. So I'll open it up to the floor.
I would say that if the training is trying to get them into the OR so that they can see vocal cords, that to me seems like under training them to do a potentially dangerous procedure.
Well, we do the OR, and then we also do it in class and stuff like that. And we also, one of the things you might think about, Jack, because you're a proponent of this, is if we leave it in, should the AEMTs take that difficult airway course?
I don't
Again,
think
if,
they can manage. I don't think they can manage a simple airway right now. I mean, I think that we should be using supraglottics for them by all means. I think that they're effective, but I don't think that there's a significant benefit to putting a tube in a hole in a short period of time. And paramedics are pretty widespread now. So I don't think we've got situations where AEMTs are transporting intubated patients to hospital.
I mean, the reality is we still do have some regions that are poorly covered by paramedic level providers, and AEMTs could offer that service to assist, particularly in a patient that has a low GCS that's a cardiac arrest. However, we would still allow them to do supraglottics, which is a true statement, and we know our supraglottics do provide an adequate area in most cases. That's why I want to open to discussion and see how this group feels. This is something that this group has to decide on.
I think we aren't looking long term. I said we are not bringing in a lot of paramedics into this field. We're losing more than we're bringing in lately, it seems like, in general across the state. There's going to be a time where areas are not going to be covered by paramedic level care. We know that an ET tube is the most secure airway if it's put in properly in any situation. I think letting the AMTs just put a supraglottic airway in, you know, lots of chances for aspiration. I think start their training now, and it may give them a little push to advance later down the road. Don't take away something they got already. If we're concerned about them not being able to do their skills, that falls on the agency in training. I think any opportunity to offer a decent airway class is a bonus for anybody who practices.
My understanding is that we would not take away the privileges from those that are already trained in doing it, but it's the AMTs that are coming out into practice that would not have those skills. And Al, I agree with you. In fact, I saw a very interesting comment made on the internet this morning that in 25 months, we've gone back 25 years. And when you look at the people that are coming into EMS, which are very few in numbers, that are coming into medicine across the boards, which are very few in numbers, we have gone back a considerable number of years. And there are regions that providers are servicing where the local emergency room has a nurse practitioner or PA who probably can't provide an airway as well as the EMS provider. So I think we need to be looking to the future, as you said, and we need to think about the future actually being backwards in the past. And where do we want our providers to be able to, where do we want them to stop providing care and just say, well, I can't go any further? So I think we need to think a moment about where we're going to be in a year and 5 years and what our providers can do at that point.
Hey, it's Jason. I agree with most of the discussion. However, one of the things that I'd recommend is that we don't make a decision on this based on feelings or you know what's been done in the past and what have you. I would love to be able to explore some data on first pass intubation success rates for AEMTs across, probably not the region because we don't have many, but across either neighboring regions or across the state. If there's success proven with the current training program and the current scope of practice with AEMTs to pass endotracheal tubes, I'd support it all day long. If the data says the training is not adequate and that the skill set of these folks is not adequate, then I think that the data would in fact show that that it needs to be removed. We kind of are sort of living in an age of data with all this COVID stuff and changes happening all the time in the name of quote unquote data. So I think we take that stance on changing based off of data and apply it to this.
Jason, just as a caveat to add to that, I mean, we don't have a lot in this region. And again, I've talked about this before with area folks and agencies and that, to the fact that yes, they wouldn't mind having that AEMT and with the paramedic, but they don't want to either increase their salary or they don't want to, for various reasons, do whatever or pay for it as far as that part goes. Coming up through, and I know a lot of you would disagree, the whole agreement with the North Country was to do away with the critical cares, which I was not in favor of for many years for that, because a critical care would outdo an AEMT, even what the AEMT has now, but the state has done away with that. Whether it will be back in 5 years because we're behind the times already, who knows? But the other issue is North Country has gone to AEMTs. If you talk to Travis and Ed up there, I think they have run several classes up there, far more than we have. I know Southern Tier has done a couple. And again, they get very few that buy into it, but if they have a class of 6 or 8, they will run it. Obviously, Monroe Livingston does not support it. The West Side, I believe they do. But I'm not sure how many regions even allow AEMTs to practice, Jason.
Yeah, and I think I don't know, John, in your network of the be possible to maybe see if they have some of that data readily available. I know we don't have it at our regional level because of just we don't have that many certified providers at that level. But maybe see if there's some data out there to maybe further this discussion not only at the regional level but at the state level, and make some good data-based informed decisions.
So it sounds like I'm hearing we need some data before we discuss this any further. Would it be okay if someone made a motion to table this to the next meeting and we try to get some data both within New York State, maybe even out of the DOT regarding AEMT and intubations?
How do you get data on the future?
I think we need to look at the past to look at the future.
With the past, we've been holding our own with ALS providers. If we're going to look at data, let's look at data on how many paramedics that are not practicing. Let's look at the loss over the last 5 years to include it with what Jason's talking about. I think that's more pertinent. You're planning for the future, not what's been done in the past. They got rid of the level 3s, the medics, so you're not going to get data on them. There aren't a lot of AMTs out there, but there's going to come a time where we're going to need them, or some areas are going to need them, or fire department first response is going to need them. And I think we got to take pretty good consideration into all that information. Most of the AMTs out there aren't working alone. They're working with a paramedic. Paramedics don't get a lot of intubation, so they want to do them. I just don't think we're going to find enough accurate data on that. I have no problem with looking. I like data to compare, but I think when it comes to future planning and problems that we can all easily foresee, we should be moving forward on that as well.
Jack, I think the other issue they had, sorry, I was doing work, so I had my computer off. I think the other issue was that the protocols were pretty specific that an AMT has to either have to go to the hospital, be the closest ALS, or a paramedic coming to them. So I think a lot of them don't like to do those skills because they feel they have a short time frame to do them. And I agree with Al. I think a lot of the times, if an EMT is working with the paramedic's going to want to do those skills over the AMT.
It's Jason again. I mean, in my personal stance right now on the skill set of intubation for an AEMT versus that of a paramedic, if I'm laying on the ground and I'm pulseless and apneic, and I can pick while floating above, I can pick between the paramedic intubating me and the AEMT from anywhere across the country or in the state intubating me, I'm going to pick the paramedic simply because of the amount of exposure, the amount of training, the curriculum differences. That would be like asking if you want an anesthesiologist to intubate you or a family practitioner PA. I'm going to pick the anesthesiologist all day long. Plans for the future? Okay, we might have a shortage in ALS. Is that a protocol and curriculum issue, or is that a system-wide issue that is far deeper than talking about the scope of practice of an AEMT? Just my thoughts, and I think I'm done on the topic now.
So Jason, if you cardiac arrest outside the pizza shop after 3 slices and a couple of pints of beer, you probably want the paramedic intubating you versus the anesthesiologist, since you haven't been NPO overnight. But if you don't have a paramedic and the only thing you've got is an AEMT, or you just got to go to the hospital and hope they can suction you, well, who would you pick to intubate you then?
I'd take a supraglottic over no airway at all. I don't know. I think asking the way the curriculum currently is across the state with the national standards, I don't think there is enough time present in that curriculum spent on airway management. It's just, I don't know. I've always, even back to the days of the old AEMTI, the old intermediates, I was leery about their proficiency in intubation then, and I think it's just a matter of time in the curriculum that's in question.
Jack, is this going to end up being a matter that's resolved by a vote by the sitting physicians?
Well, keep in mind, the REMAC is open to everyone, but the voting members are the physicians. So this is going to end up being a vote amongst the physicians.
And I don't want to speak for the physicians, and certainly, you know, yourself and Jamie and those others that have had clinical, you know, pre-hospital experience. But this is, to be honest, this is going to be a very difficult question for me to answer because of. So what we're, I mean, I understand what we're trying to get at, but in the end, I'm not sure how I would go about making a recommendation for or against. Marita, James, do you guys have similar challenges here, or am I off base?
No, I'm with you. As we're discussing this question, is when I got a little nervous when I heard that, this was going to potentially be a physician vote, because I honestly don't have nearly enough information to make an informed decision on this. And I'm right there with you.
I agree. You know, Jason and looking at the data would be more helpful for us. I am very hesitant. I want the most qualified person, you know, doing the two, but otherwise I'm comfortable with supraglottic training. But again, want more information.
I think we're going to have to table this today and get some information. But what I want you folks to think about, and what Al was alluding to, is that if we continue on the same path we're heading today, in a year or 2 years, we will have lost a very significant number of our current paramedics for multiple reasons. They're aging out, they're burning out, they're moving on. We are not bringing new paramedics into this industry. There is no incentive. They don't want to come in contact with COVID, influenza, drugs, alcohol, and all the other stuff that they have to put up with. They're not getting paid to do it. They're not getting any benefits. So as we lose more and more paramedics, despite the fact we would all love to see a paramedic on every single response, the reality is that may not happen, and we may not have paramedics responding. And as you get into the more rural areas, we will probably have less and less paramedics responding. Even with a first responder crew showing up and starting to stabilize the patient, there may not be a paramedic. And the closest ALS may be the emergency room, which might be a critical access facility not staffed by even a physician, with enough physician not available. So if that's the scenario we're going to see in a few years, picture yourself making a decision. Do we want to have EMTs or CFRs responding? And that's the highest level of care. And if there's a difficult airway to manage, they can put in a supraglottic airway. Keep in mind, if that patient's vomiting or is a difficult patient, those supraglottic may not be the best thing in the world to have, versus someone who has some training in providing an appropriate airway, which we still consider the gold standard, and might protect the airway. And that's a scenario we have to plan for a few years down the road. I personally, I'm going to be retired and I'm going to be the recipient of that. You guys are still going to be practicing. I'm just trying to set the stage.
Just to add into that, Jack, if you look at the curriculum, national curriculum, Jason, basic EMTs are being taught in other states how to insert supraglottics on very little curriculum. Not that it could not be improved. So I think at least the curriculum for the AEMT is better than the basic curriculum for the supraglottic. I really do feel that. So, and it's not into anything that we could not expand the AEMT curriculum a little bit more for here. Again, that's all, you know, money driven as far by a lot of agencies or whatever they offer it. They can only afford so much, you know, pay for their instructors for so many hours. But if anywhere were to be expanded, it definitely would be airway.
So yeah, Donna, it's Jason. I totally agree. You know, Jack, where to kind of give you the background on how this made it to SEMSCO, not to SEMSCO, but Med Standards and REMAC, is the Education and Training Committee looked at the national scope of practice for levels of care and New York. You know, maybe making our AEMT curriculum mirror the national, to maybe make it a little easier for some of these providers to come into New York and not have to sit for an exam or sit for the class. Just make reciprocity a little bit easier. Now, I saw in the protocol group discussion an idea of regionally equipped and trained, and I would support that entirely. So if the region, you know, the Finger Lakes region wants to do an airway management for the AEMT, and then not credential them to do it, because we can't do that, but make it a recommendation to their agency medical director that they have met this criteria, then I would support that entirely. But I think at a statewide protocol level, not protocol, but curriculum level, making it mirror national standards. So maybe somebody that, for whatever reason, decides to move to New York from North Carolina that's an AEMT can still practice here, would be huge. And then, you know, do that little caveat that we have in the collaborative protocols of, if regionally equipped and trained, boom, we want ours to intubate in this region, we could train them to do that.
Well, I don't have the data in hand, but I can assure you that there are way more providers leaving New York going elsewhere than providers coming to New York. And that's at all levels of healthcare, even at the physician level. But yes, I agree. It would be nice if someone wanted to come to New York where they could just step right up because they've been trained the same. But keep in mind, by lowering our standards in New York State, we're not really doing our patients any good. As an aside, we are saving the state a lot of money, but I'm sure they're more concerned about healthcare than they are the costs.
I guess it's a bit of a double-edged sword, right? You know, we're worried about the highest level of care, but at the same time, we've got to have people able to do it, like Al mentioned. So I guess we need to figure out which envelope we're going to put our money into, so to speak.
All right, I
play it
think
safe, do both.
I'm sorry, I'll say that again.
I say play it safe. Let's work on both.
Al, I think you just volunteered to chair a small committee.
I'm sorry, I think my internet cut out.
I'll send it to you in email, but thank you very much. Let's move on, guys. We're not going to come up with an answer to this today. We'll get together a group, try and maybe bring a little more information, see if there's some data from the state, from the DOT. Let's get some legitimate numbers, whatever exists, and we'll come forth with it again at the next meeting. John, put it on the agenda for the next meeting, would you please?
Sure.
Jack, I'll be glad to head up that committee. I just got a quick question, maybe John would know. Would that information be in the state EMS bridge? Would that be a good place to start?
Yeah, Al, I think between the bridge, maybe Susie Supernock from Central, Travis Howell from up north, and maybe Ann Smith from Fort Drum seem to have the biggest cluster of AEMT stuff.
Okay, great. Thanks for a place to start.
Okay, guys, let's move on. I have the New York State DOH investigations list.
Jack, you cut out. You're on mute. You're on mute, Jack.
All right, can you hear me now?
That's better.
If you minimize Zoom, you can't unmute yourself. So name number one is Christina Consento from Bethpage, New York. And she has voluntarily surrendered her cards for violations of 10 Part 815B, 800.16A, 2 and 3. And no, I don't know what they are, but it must have been bad enough for her to surrender her card. And number two, actually there were three, I guess. Letitia Wright from Staten Island for violations of Part 800.16A and 2. She was revoked effective 7/20. And last but not least, Frances Feely of Cohocton, New York, voluntarily surrendered February of 20 for violations of Part 815B, number 1, and 800 Part 16A, 9, and 10. So those three people you should be aware of. If any of them are working for you, please notify the DOH. Okay, we have not had a recent state meeting. They were supposed to have meetings in October. I believe they've now delayed them till November. We still don't have a set date. So I don't really have a lot more to report from my chair. Matt, do you have anything that you would like to add?
Just a general comment, wondering if anyone saw the Colorado Society of Anesthesiologists come out requesting the state to review the waiver for ketamine for delirium. They had a bad case out there, and if any of that is going around in New York.
Hey, Matt.
Okay. Yep.
I think it's Jamie. The National Association of EMS Physicians actually came out with a statement responding to that, which I think very clearly stated that EMS should not be using ketamine purely for law enforcement issues, that they should continue to use it for excited delirium. Because I think the issue was that the case in Colorado was a restrained patient, but it was purely for law enforcement. It wasn't excited delirium. It was used as a chemical restraint to facilitate a law enforcement action. So any EMSP just came out this week with a statement that basically said EMS should not be used for law enforcement actions and the medications they carry, but they should continue to use them for excited delirium.
Sure. Yeah. I think that in the current political climate, that was when you read through the story, it makes it seem that it was at the pure request of law enforcement by the agency, and maybe there was some pushback from the medic involved. And so I know as medical directors of our agencies, something to just keep in mind. So
I think the other thing is that the dose of ketamine that was used in that case was much higher than is used for excited delirium in our protocols.
It's 500 milligrams. Yeah. Okay, that was all for me.
Production dose. Marita, you and I had emailed about this as well, and I still believe ketamine, if used properly in the appropriate doses, is safe, and it's really the only thing we've got left in EMS. We still carry Versed, but it's not very quick acting. Unfortunately, we've lost our access to droperidol and Haldol in the EMS setting, so it really doesn't leave them a lot when they get into a patient that's violent and dangerous.
Yeah, no, I understand. I think it's a controversial topic, and I think it's going to become a larger topic in the layperson's discussions here as things go on as they are, kind of culturally. I just want to make sure too that our paramedics are doing it on their own medical judgment and never influenced by outside or bystanders that because oftentimes these people can be talked down, and I just want to make sure they're not rushing to sedate people because we lose medical information and a clinical evaluation sometimes if we do it too quickly.
John, that sounds like a great topic for the conference in February.
Are you going to present that?
Well,
I personally think
we
it'd be a
could
better.
do it as a group.
I agree. It would be better a roundtable.
Okay.
We could get a couple of docs together, a couple of providers, come up with some cases, scenarios, maybe bring in someone from CPEP.
Jack, I think we've had pretty good success with Sheriff Henderson participating in our conferences. Maybe in that roundtable, include him or somebody from his office with a law enforcement perspective as well.
Interactions between mental health and public service.
That'd be interesting. That's exciting.
All right, John, put it on the list.
I've got the note written.
I see you writing. Scott never signed on, did he?
He did not.
All right, we do have some exciting stuff. We're going to move on to RSI and RSA committee.
Sorry about that. Like I said, doing some work. I'd also like to volunteer for that that panel, since I have some experience with giving ketamine and repercussions about it. We'll do RSI real quick. I'll hit the highlights of it. We talked about the pandemic, the RSI agencies that were grandfather for the pandemic. I just did a letter yesterday, John. I hope you got it. That will expire on October 1st. Basically, the letter was thanking them for their participation and that they are more than welcome to apply for full RSI status. Like I said, that'll end October 1st. It's up to the agencies that are sponsoring them to make sure that everything's done. And then just have a little email to the committee that it was done. The big topic was SCT to RSI and SCT providers doing RSI. We had a very lengthy discussion about that. And basically the consensus of the committee is that it's probably more a agency problem, because this is not going to be a field RSI. This is going to be an RSI for an extubation of a tube. So what the committee decided is Jeremy Harris, Dave Dowdell, and Matt Sproul are going to create a protocol in conjunction with the agency medical directors of their SCT agencies to discuss a paralytic protocol for reinsertion of a tube. The SCT providers will be encouraged to take the RSI class, but again, this is not a field skill. This is an emergent skill during an SCT transfer, because 99.99 times out of 100, the patient is going to be intubated or should be intubated when they do the SCT transfer. So this is more of a emergent skill, not a field skill. And we're going to hopefully have that by next REMAC. And then we talked about the RSI class. We are going to have another RSI class. I have set the drop dead date for enrollment by December 31st for a class in 21. If there is significant interest, and I haven't heard rumblings of significant interest, but I have not received anything formal, we will push this class up to this year. But it's going to take a significant number of people to push that up.
Finger Lakes has 12.
Okay, Al, can you send me an email of that? I'm going to send out another email. I'll send out another email today. Can you send me the names too? And then I'll send out another email today, see if I can get anybody else. Dr. Siret, did we set a number? Was it 20?
I think we'd said if we get 20, we'll do the class.
That's what I thought.
Ask that please look at the criteria for the medics for RSI. Spend a lot of time reviewing people's credentials, and it's frustrating when people are put forward and they don't meet the criteria. So it would just make our committee more efficient if you've kind of pre-screened the people, you know, and that goes for anyone. It's really frustrating when we get someone requesting to join the RSI course and they've been a paramedic for a year and it just doesn't meet the criteria. So we're willing to consider anyone, but you know, it would just make it more efficient if they're pre-cleared by the agency.
And I'll definitely send the names to everybody when I get them. Trying to think. I think that's everything I have for RSI. We're gonna have another meeting probably next month. But I will send the names out as soon as I get them. I'll send them out to the committee.
Thank you, Mike. You want to keep moving on?
Yep. Moving on. So I don't know if you want this now, Jack, or you want new business or old business, but basically for the meeting, and I'll get to the stuff that I wanted to present today. We talked about some alternative medications. I know Dr. Davidoff had sent out you're working on a list, correct, of alternative medications. I'm working on it as well. Also, we're still focusing on attendance. I'm asking the medical directors just to please make sure that not only for ALS committee, but for RSI meetings as well, is that you do have your agencies represented. This is some important stuff going on, and it's been a hot button for years, attendance. I know that we've been working hard, and I thank the committee for everything that we're doing. We're working hard on a lot of things, and we brought three things, well, two things to definitely present and one thing to talk about. You want me to do it now, or you want me to wait till old new business?
No, keep moving.
Okay. The first thing that we want to talk about is the SET protocols. I had sent out yesterday the SET protocols. Jeremy Hares, who did a great job, by the way, just sent out the last updated copy, which was sent out 2 hours ago. The only difference between the copy that I sent to you guys and the one Jeremy has, it has a couple new medications. I believe pantoprazole was one of them, and there was a gastrointestinal hemorrhage protocol we've been working on, a GI bleed. I don't know how you want to proceed. I know that there's some formatting things. My intention was, if this body voted on them today, I would ask that the motion would read once formatting changes are completed. It's just, taking the font colors out, making one uniform font, and then just taking the spacing. Everything has already been proofread and spell checked. It's just the different colors to show what is added. I don't know how you guys would like to proceed with that.
Well, you've brought something forth for this body to discuss and vote on. So let's open it for discussion.
Hey, this is Doug. Good morning. I had sent these out before, and I don't know if they were dropped as considerations, but a couple of corrections and possible additions to consider. 2.08 for the bullet point number 5 for the patient intubated. It says, bullet point 5 says patients intubated for greater than 4 hours. It should read less than 4 hours for OG or NG tube insertion for evacuation of contents. Another consideration for the blood protocol, whether it's accepted or not, the blood product should be administered through a fluid warming device and not just running cold. And 2.16 for the ventilated patient, bullet point 4, should be pips and p-plats measured, not PEEP.
Doug, I know I made those changes in a couple of versions. I'm not sure if the last version that Jeremy did made those changes, but they were made.
Yeah, they're not in the latest version that came out in the last email.
All right, I'll make those changes.
My feeling about these things is we use more as guidelines and protocols. I think that previously we've used protocols to supersede other things. But in this case, because it's SCT, I think that they should be used as guidelines in the absence of any specific direction by the hospital. And that allows the hospital to manipulate the patient medications the way that they see fit, and it also makes it a lot easier to change guidelines than to change protocols. What I don't want to happen is a hospital's running at a protonic strip at 80 milligrams an hour, and then someone says, well, my protocol only lets it happen at 40 or something silly like that. Whereas, so by giving the hospital the ability to supersede the guidelines, then I think that would make it a lot more flexible for critical care transport, because my experience is that these transport protocols change frequently and often, and they're often both healthcare provider specific and also healthcare system specific. So how someone's managed when they're transported to Rochester General is often different from how they're managed when they're transported to Strong.
Jamie, I agree with that statement 100%. I would also just caution when these are adopted that if it is recognized as a guideline and something falls outside the parameters of the guideline from the sending physician or the receiving physician, that those things be documented clearly in your pre-hospital care chart.
Jamie, I would agree. I think what you said is the truth. These are guidelines more than anything else. The most important part of the guidelines was that medical control needed to be more involved in who medical control would be. And that was really the key. Plus, the other part of it is equipment. We run into problems when agencies show up and take equipment they haven't trained on before. SCT needs to be done properly. They need to have proper training, proper medical control, proper equipment, and guidelines to work with. And that's what we're trying to set up here. The other part of this, which is not available today, is that we're working on a new order sheet that would go with these guidelines, maybe better than protocols, that would allow the medical control, the sending physician, to have better say of what's going to be done to this patient. The current order sheet is rather limited, and I find a lot of times doesn't really fit my patient. So we're trying to come up with a little better sheet that would allow them to put the orders down for the providers based on what they're currently doing, what they'd like to see done. And if the sending physician doesn't do that, then they would utilize their alternative medical control agency, regions, etc.
Jack, does not also have to be approved by medical standards as well, being a guideline or a protocol? So, I mean, once they're past this group, then it gets submitted up to the state level for their blessing.
Is that the case with this?
Jamie, you just cut out.
Jason,
Is that a case with SCT that the state has to approve? Because I didn't think that it, because it's not covered under Part 800 or Article 10.
I didn't think they had to
Right.
either.
Yes, Jason, I agree. SCT falls out of the purview of pre-hospital care. It's clearly defined in minimally the collaborative protocols as a hospital-to-hospital issue, and falls outside of that the purview of that anyway. So I would highly doubt that it needs to go to Med Standards and CMAC for approval. I think this is a regional thing.
Well, the question arises because Mercy Flight's protocols all needed to be approved, which are essentially the same thing as this, on an expanded scope.
No, Mercy Flight's protocols were approved on the basis of their field response, I believe. That's they use a consolidated protocol, but I believe they're put to medical standards and to the CMAC and to the REMAC for the pre-hospital care component in field response.
That's correct.
I'll have to double check, but I think that is correct. Yeah.
Doug, what was your comment? You recovered.
No, Jamie's correct there in that, and Air Methods also uses the same process. It's defined as field responsive. I think incorporates inter-hospital as well.
Okay.
When it's sent to CMAC.
The other component I think is important within these guidelines is to make it clear that the SCT unit is not to be utilized as an increase in level of care. We shouldn't have a situation where they say, okay, get the person on the ambulance and then initiate all these things because we can't do it in our facility. These guidelines are designed to transfer a patient from place A to place B, not a new management plan unless the patient deteriorates and it's a response to that deterioration.
I would agree with that as well. Well said. I would like to bring these to the state level and see if they have an interest of utilizing them throughout the state. But I think if we approve them in our region, we can use them without state approval. But the state may be interested in these because currently we don't have any statewide guidelines for SCT transport.
So I think my feeling is that these protocols, to a large part, are minimally controversial. I think that it's difficult bringing a whole set of guidelines or essentially a book of guidelines to the REMAC and asking them to just approve them. What I would suggest is once they're finalized, they're sent out, and then we're just allowed to review them. And we can, if there's any particularly controversial issues, we can come back together.
Are you allowed to vote electronically outside of this meeting?
John, what are your feelings on that?
My understanding is we would have to convene a special quick meeting amongst the doctors virtually so that it can be captured electronically and posted for verification means.
Again, because it's not covered by Part 800 or Part 10, technically it doesn't fall under the requirements for the state. So we can really, we're an approval committee by default, not by state mandate.
Yeah, but the REMAC itself is a state, is required statutorial. So that creates a little wrench in things.
So I guess I got a quick question about this. Ultimately, the physician who's sending a patient out is responsible for this by law currently, right? So wouldn't we want the hospital medical directors to get on board with this just to say, yeah, we like this idea? Because if ultimately we can do whatever we want, technically they're responsible. I think having some conversations and maybe a sign off from the hospitals that we transfer out of, not to, probably should get involved with this. Plus it might open up some communications for further discussions down the road.
I think every member of every hospital has representation on the REMAC, which is why this is a good forum to discuss it.
Well, I agree, and I do believe we need to support it. Is this the final draft? Because on a blood transport, obviously it's something that we've struggled with. I'd like to put in a couple of things that would help our sending hospital with blood products while we're still waiting for the state to sign off on, a new process. Is this the final draft?
This does not have to be the final draft. This group has every opportunity to make changes, additions, subtractions to that, and that can be very easily done.
That'd be great. I'd love to throw a sentence or two in that would help me get our lawyers on board with sending blood. So that would be great.
Do you folks want to table any further discussion at the REMAC meeting on this to have an opportunity to further review, make some changes, and we could set up a separate meeting next month sometime to review and possibly approve?
Jack, I think that sounds good. Just one question, and obviously this took a lot of work, so thank you everyone that did this. And looking through this last draft that was presented yesterday, is the font that's in red, is that removed?
Oh, no, that was changes. I just sent everybody the updated copies. I just made changes as we're going along. Those are additions. We just kept it in there to show everybody what was in there, what was changed.
Okay, so what is the distinction between the font in green and the font in red?
So honestly, Matt, I can't answer that because that was Jeremy Harris, and I don't know if he's here. I'm looking.
Okay.
So I can't.
It's just different people put in different colors.
Okay.
Yeah, I think that's what it was, but I can't give you a 100% answer on that.
Yeah, but as it is, whatever's contained within this is the current working draft.
That is correct.
Okay.
Are there any new medications on here, or these are all the same meds that you all carried before? Were there any additional meds?
I believe they added pantoprazole, and maybe one other one. Anything in green.
Tranexamic acid was added too.
Okay, that's new. That's what I was questioning. Okay.
We tried to cover what we thought hospitals would be sending patients out on. And that's, again, as someone had said earlier, it's not that we're going to necessarily use tranexamic acid in the field or that we're even going to institute it, but if the patient has already started treatment with a drug, we want to be able to continue it appropriately.
Right.
So everybody should have that. I just sent it out as we speak. So that's the latest with all the changes. With all the changes that were made. Real time.
I guess I'm looking for clarification still. Ultimately, if we're shipping a patient out and we're doing the transfer and something goes south for whatever reasons, or there's a mistake made on the orders that the physician gives us, where's the liability shift for us with this? Is it the ownership of the transferring physician, or once it's transferred into our hands, it falls under our jurisdiction, our medical director's jurisdiction?
EMTALA clearly states that the sending physician is responsible for that patient until they arrive at the receiving facility, that the transport has to be made with the appropriate capabilities, and the facility receiving has to be capable of and have room for caring for the receiving patient. So the responsibility still lies with the sending physician. Now, technically, for example, at Finger Lakes or one of the other agencies that uses their own SCT medical directors, there would probably be some shared liability, but the majority of it would still fall on the sending physician.
Yeah, Al, I think that the state kind of goes on to say that unless there's a transfer of a clear transfer of medical direction. So when you fly someone, we recognize that that aeromedical is not within the general knowledge of the ER sending physician, and there may be specifics. So at the bottom of the flight form, it actually says that you transfer a medical direction of the patient during the flight component to the flight medical director. So if there's a clear transfer of ownership of the patient, there's shared liability. If there's no clear transfer, then it's on the sending hospital to ensure the safety of the patient all the way to the hospital.
So Dr. Surratt, just for like our agency, we do these. Is that something you think we should be adding to our forms for them to sign off on?
So I think that my personal belief is that interfacility transfer has become a specialized area of medicine, and it may or may not be under the knowledge base of a sending physician or facility. They may simply not understand the capability of EMS. So I think that there should always be a transport medical director involved in a conversation, even if it's brief, to make sure that what the hospital's wanting and what EMS can provide are in line with one another.
So can we educate our hospitals that we deal with about this and say, hey, if we're going to be doing these transfers, they need to understand that we are going to contact our medical directors for orders and everything else, updates. Because realistically, we're never going to get a hold of the ER doctors. Either A, they're going to be too busy, or they could leave off shift.
Yeah, that's all part of the contracts you're meant to have with the hospital.
Thank you.
So I think we really should have a motion to table and to back.
So moved.
Second from Cullinan.
Is there anyone opposed to that? John and Mike, we have, hopefully everyone has updated copies, as you said, Mike. John, can we put together a request to the REMAC, the voting members, to get back together? We could open it up to the entire REMAC if we wanted, but we're going to need to have a short meeting sometime in 3 to 4 weeks to finish discussion that we can send out copies, changes, whatnot, via internet, but then have a meeting in person or virtually, I apologize, to vote on a final draft so we can move this ahead.
Yeah, I did send it out to everybody. If anybody didn't get it, please let me know. I just sent it to the docs. I didn't send it to the entire REMAC. If you'd like me to, I can.
Let's open it up to the entire REMAC. I would like to have everyone's input on this. Obviously, the vote's going to be the voting members, but I'd still like to have everyone's input. Let's have all the changes, suggestions. Let's gather it. Let's discuss it. We can do most of that via email, and then we will have to set up a meeting in 3 to 4 weeks to have a final vote. John?
I'll send out.
What was your question? My phone was ringing over on my end.
We're going to need to set up another virtual meeting of some type in 3 to 4 weeks after we come up with the final discussion. That's my question. Can we do that?
We absolutely can.
I kind of thought so, but I need to hear it straight from your mouth.
Should we maybe also, once we get the solicited or the what we believe to be the final draft, should we send that to maybe the department head, the ED directors or whatever, and see if we can get a letter of endorsement to copy it with those
I think all the ED directors are on this call except Dr. Osborne.
He was on it. He is still on it.
Oh, he is. Okay.
Yep.
My suggestion is that the motion should come from the medical directors of the SCT transport agencies, and the vote should be by the medical directors of the hospital's ERs.
Rather than the REMAC?
I don't think SCT is, or I mean, ultimately it's the hospitals have to approve the protocols, right? Proposed by the members of the REMAC to the hospitals for this is what we
So it
want
kind
to
of
use.
brings us in a 360, because at the beginning of this discussion, we kind of talked about this was a REMAC regional, proposal here. So it makes sense, I think, that all of us review it and all of us should sign off on it. You with your specialty on the EMS side and us with the sending hospital side, that we're both agreeable.
I think having members and representation from all the hospitals in the region. That's the connection between the hospitals to the REMAC, but I still think this is a REMAC project and we need to move ahead on. We're the ones that are going to be doing the quality assurance. We're the ones that are going to be adding, subtracting, changing as things go on. So I think this still goes back to the REMAC.
Jack, just to circle back around, you made Dr. Talbot and Dr. Cullinan made a motion to table it. You just got to get all the ayes from the docs.
All right, so there is a motion. Is anyone not in favor? Please speak up. All right, so that passes. This is tabled for the discussion via internet and a vote at a later date. All right, moving ahead, I don't believe we have anyone here from New York State.
Oh, I had two more things, Jack. You want me to wait?
No, I'm sorry. I apologize. Go ahead, Mike.
The second thing was the nitroglycerin protocol. I feel that probably should go along the same lines as the SAT guidelines. Maybe respectfully request a motion to table. I know there are some questions on the packaging. I'm not sure if everybody got a chance to fully look at the protocol. And also with the questions on the packaging, I'm wondering if we should table this for further discussion as well as to not take up a lot of time.
Did you get the material I sent you from Newark's Pharmacy?
I did. I don't know if I sent it out to everybody. I can. There was some question on whether glass bottles were not allowed up to 500 or 499 or milliliters or stuff like that. I'm trying to actually find your email.
Mike, it's Jason. There was an ad nauseum discussion about that at the CMAC and SEMSCO levels. Part 800 currently does not allow an EMS service to carry a glass bottle that exceeds 499 mLs. There was a vote by CMAC and SEMSCO to allow the Bureau to do some emergent regulation changes. However, those have yet to occur.
Okay.
So it sounds like putting that on the table for the time being is probably appropriate as well. So again, looking for a motion.
Sorry.
This is Marita. I move that we make a motion to table this discussion as well.
I'll second.
All right, so same thing again. Is anyone opposed to tabling this and discussing at a later date? All right, thank you. Mike, what else have you got? Sorry.
The last thing I have is the regional clearing guidelines. I saw it was under old business. That's why I wanted me to wait. But I have changed everything that was sent to me. I did include AMTCC, which was out. I did put everything back in, so the wording does reflect. And I did send that out about a couple weeks ago, and I know it was sent out again. Your pleasure on that document.
This is a rather important document. It's not that long. I would really like to have some discussion and see if we can move ahead with it.
And it's definitely written in there numerous times that it's a guideline, and it's suggested it's not a requirement because I know we can't have that.
Where the discussion came up is creating a system-wide standard in which we ask agency medical directors to buy into in the clearing product, creating a minimum standard in which everybody is cleared to. It doesn't mean that agencies can't go above and beyond that. It just creates a minimum in which they need to follow.
Yeah, the only thing I wanted to add was if you're subject to a remediation program or process in another region, and you come to our region and ask for regional clearance, you have to complete the remediation program or process in that first region. You can't simply jump regions to avoid remediation. So you can, if you've got a remediation process going on, in MILREMs, you can't just come to Finger Lakes and practice because you don't want to do it. So
You want me to add that real quick?
that was a request. It seems like if you need to remediation in one area, you shouldn't be able to clear in another.
If you're dealing with the QA, QI process, I'd be very careful about pulling QA records from other regions, as it's not a punitive action. It is a quality assurance improvement for that agency.
But when a provider comes to this region and has worked for an agency, they need to disclose that.
And they need to
if there's under any investigation, they certainly should. But if it's a quality assurance and improvement process, it should be specific to that agency. I don't argue the validity of why you should be able to do that, but there is a gray area of legality of doing that.
So if I have a remediation plan at AMR that involve patient care, significant patient care issues, and I come to this region, shouldn't that be notified? I mean, I understand, Doug, my feelings on QA and all this, but I think that if there's somebody having a remediation plan in one agency, it should be known to the agency they're coming to, both from a leadership standpoint and a patient care standpoint.
Well, I think it should be on an individual basis, and you have to look at what exactly you're talking about. And I'm not a legal expert by any stretch of the imagination, but there needs to be legal considerations with that, and someone that might be more in tune with that should probably look into that a little bit further.
What about
Jason? If we're gonna include this, would it be in the better interest of the REMAC in the region to send this question to legal counsel for their advice?
I think from that aspect, it should, because you don't want to get caught behind an 8 ball again in a situation that could have been prevented from the get-go.
So can I just?
Yeah, we've done that once. We don't want to do it again.
Let me just ask this question. If we don't add it, it's the onus on the agency, correct?
Yes.
The agency should be asking any new members, do you have any QA issues or infractions holding in another region? And if they say no and you later find out, that's grounds for dismissal. If they say yes, then you need to get their written consent to look into what those are.
If
Jack,
we're not,
can I add something real quick? Is it allowable to ask a person when they're coming from another region to ask of a letter of good standing from their previous region?
There's no issue with that at all.
Because I think that would be a good standard request, when somebody's requesting new privileges in a region, in that packet, that they should have a letter of good standing.
I thought that we weren't having our provider. I thought we were notifying. Are we still going to? Let me rephrase this. Are we going to start notifying our region now of providers that were cleared? I thought we got away from that in the past. Because I know in the past it was supposed to be a notification to the ALS committee, which the ALS committee was supposed to notify the REMAC. I know in other regions, and using Melrem's as an example because that's where I came from. The ALS chief would notify the ALS committee, and it would be brought at the ALS committee meeting as new providers, and then the meeting minutes would be sent to REMAC approval for the new providers.
We have not been doing that.
I think with the current environment and the issues brought forth by the 1401 case, that those names, if they're read or entered into any REMAC or ALS committee minutes, would have to be for information only. They don't need to be approved. And realistically, statutorily, they can't be approved.
What I was getting at is if we don't put this in this document, because we're not regionally clearing people, it would be the onus of the agency. So it would be the agency's responsibility to make sure that their providers don't have any, if they have a remediation plan that should be completed. It would be the onus on the agency, not the region, is what I was trying to get at.
The concept behind this work that you did was not to hire or not hire. It's once you've got through the hiring or membership process, how they get cleared to provide patient care. And I think opening up the other door is I don't think we want to go there right now.
I agree. I think this is just this is just so if somebody comes in, you have a blueprint or a document to look at and say, okay, so, instead of making somebody with 25-year experience do 15 calls or somebody with no experience do 1 call, it has a guideline. So an agency leader or ALS chief or chief can say, okay, we're going to do this, but if we feel we need to do more, we can, but this is what we need. This is a good place to start. I think that's all this document should be.
Mike, in line with the other issue we had in regard to kind of right to work, if you go down to non-compliance of requirements under the 3rd bullet, it says any modification of this rule must be approved by REMAC with recommendations from the Advanced Practice Committee. So that rule is referring to needing to do minimum procedures. So then, just to clarify, would that fall back to the medical director's responsibility, or is that a REMAC issue?
That's a good question, because that is we had talked ad nauseum at the ALS committee about setting what's called the 90-day rule, which means that there needs to be one documented procedure every 90 days. That's where that falls under, Dr. Talbot. And I believe that's where, because REMAC had suggested to the ALS committee that there needs to be some sort of guideline as to how many days a provider can go without doing a documented skill. That's why it was written in there that the REMAC would be the ones to modify it with the recommendations from the Advanced Practice Committee.
Got
it. Now it can fall under the agency medical director. I know that every onus of these committees is obviously going to fall back to the agency medical director, but because REMAC had made that suggestion to the ALS committee is why that was written in that document like that.
The authority still lies in the agency medical director. The REMAC's role is to make recommendations, try to keep those recommendations up to date. We do have some authority over the agency medical director, but it's ultimately the agency medical directors have authority based on the current New York State rules and regs.
Would you like me to remove that sentence or keep it?
I think, yeah, I think it's a good document. I think it makes sense, but.
Any further discussion? Is anyone willing to make a motion that we move this ahead?
I'll make the motion. These guys have done a lot of work. It deserves to be brought forward for formal vote.
Anyone second?
I'll second the motion.
All right, thank you. John, do we technically need to have a roll call? Are we okay with a show of hands? What do we need to absolutely do now with everything changing?
Well, let's just do a quick roll call with the docs that I know that are around here. Dr. Glick.
I vote yes.
Dr. Talbot.
Aye.
Dr. Surratt.
Yes.
Dr. Montesano.
Yes.
Dr. Osborne. Will you sign off? Dr. Michelin.
Yes.
Dr. Cullinan.
Yes.
I believe I got all of them.
I would believe it passes.
Thank you, everybody. I appreciate that. That's actually all I have. So thank you so much.
Mike, you guys have done a lot of hard work and it's really appreciated. The SCT protocols, I think, are a huge step, and we will further discuss them, make some modifications, and then we'll get that voted on at a later date. Thank you again to you and your group.
No problem. And like I said, if if any physician would like to attend and participate in the ALS committee and RSI committee meetings, that would also be greatly appreciated. The more help we have, the more ears and wisdom we have would be better. Thank you.
And please keep me up to date on who is and who is not attending.
I will.
Thank you. Scott, are you still online?
Yes.
Anything you'd like to add to the group? You weren't online earlier.
I apologize for being late, guys. I'm driving my dog to the vet right now. But I kind of came in halfway through the discussion about the approval of SCT protocols and where a lot of the responsibility and legal responsibility, lies with the agency medical director versus the ER medical director. And I agree with all the points that I heard so far. I just wanted to, to basically say, the point of it is not to make just a protocol set that's that looks appealing to the, to the emergency departments, but to also have an education piece to the emergency departments of what is available, for pre-hospital, for interfacility transport. So if they, if we write a good set of protocols, and I have confidence that these SCD protocols are good, we should work with the emergency departments to say, well, what's the discomfort, with using certain medications, certain protocols, so that we can refine it. I guess where I'm going with it is I don't want to make it more difficult on the interfacility crews. I want to make it easier. The whole idea of the protocols and the ACT protocols are to find a core set of skills and medications and procedures that, our crews are comfortable with, so that we can continually, hone those skills. But we should also kind of hone our emergency departments in a way.
I would agree.
Other than that, I just really want to thank them for all the time they put into these protocols. We, as physicians, we take the time to, attend these meetings and give feedback, but they really are working during the week, back and forth, lots of emails, lots of meetings, discussions. So I just want to say what you were saying, Jack, basically. I just really want to thank them for it.
The heart of Finger Lakes EMS, and they keep it beating. So great job, guys. Keep it up. Thank you very much. Scott, anything else you want to add? All right, let's move on to agencies. Mercy Flight Central. Erin, you still there?
I am. Just a couple quick things. We have our education day that is typically for the east side is going to be remote this year. So it's registration is open for that. It's October 2nd on our Facebook page. And I believe it's been sent out to everybody, but that'll be available. And we are back in scheduling some ground school. So if anyone's in need of a ground school, we are back to doing some of those. That's all I've got.
Very good. Thank you. LifeNet Guthrie.
Doug had to jump off. He had to go do a call.
Okay. Well, hopefully he flies safe. Finger Lakes Ambulance. Al, I guess we lost Al as well.
Jason Bortle, are you, anything from you that you might be able to pass along? Okay.
All right. If either one wants to hop in later, we can certainly do that. Thompson Health System.
So we've actually noticed frequently we've had some phone issues intermittently, and I've been spending some time in the last few days contacting a lot of agency directors and chiefs and whatnot. They will be seeing a mass text blast go out that we're going to start using for emergencies in that situation. You may see that coming. I talked to
probably most of the area chiefs throughout the day yesterday, so that should be coming out in the next day or two. Let's see. And the only other thing that I was reminded to tell everyone, if we can take it back to everyone, is to notify the ambulances that they can't be idling outside the emergency department. If they are going to keep their ambulances running, they need to be parked across the street and across the parking lot.
All right, Chris, thank you. Anything else? Telecommunications service across the region seems to have deteriorated in the last few weeks. We've seen issues left and right, cellular. It's been quite an interesting few weeks with communications. I think the concept that we're going backwards in some respects is very true when we talk about communications. So we'll keep doing our best, but yes, try to make notification of EMS agencies and dispatch centers so they can utilize alternative communications. And hopefully we can get through this. Next on the agenda, Clifton Springs Hospital.
Hey, not a whole lot new from us. Been very busy with lots of psych volume, but otherwise kind of status quo.
All right, very good. Mentioning mental health and psychiatric issues, let's all remember to keep an eye on our providers as the COVID stresses and all the ramifications from COVID start to get to them. Keep an eye on your partners, your colleagues, your neighbors, your employees, your employers, and let's try and get everyone through this. Finger Lakes Health.
Nothing additional, Jack, just echoing the point made earlier about a lot of these patients we're seeing, it's kind of the silent COVID. So just a reminder on PPE.
Thank you, Matt. Yeah, we cannot let our guard down, not right now. We've got to be really cautious. We've already got a few providers that have been infected, a few that are at risk and on quarantine. We don't have the resources that the larger areas have, and we've got to be super cautious at all levels. So thank you. And finally,
one more reminder, sorry. New York State actually amended their essential worker exemption. And so now, and this would come into play if there was a quarantine order that a potential employee was placed under, that the verbiage in the law now states that you have to prove that it would affect your operations in a manner that you would be unable to fill that gap. And you're supposed to have that signed off on by the director of human resources or the director of the agency. So, I'll give you an example. There was a nurse practitioner, within the organization who was placed on a quarantine order, who we attempted to use the essential worker exemption. The county health department and the state declined that request.
yeah, we're all in a bind over this, I guess. And I think right now being cautious is the best thing to do. Thank you. Last but not least, North Wayne Community Hospital.
I don't have anything to report today, so we're status quo right now.
Excellent. Thank you. All right, we've been through the old business. Any new business that anyone would like to bring forth for the Finger Lakes REMAC?
Just very quickly, Jack. At a request from law enforcement in Wayne County, we have an active tactical medicine team that is run by the county. There was a request for utilizing TXA for the tactical medicine team. and I said I would bring it to the REMAC. Is this something that you want me to develop further, or is this just a non-starter? The argument would be that these teams work on national standards, and TXA administration by tactical medical teams for penetrating trauma is the national standard. It may not be the local standard, but it is the national standard, and it is the international standard. And there's an obligation for our medical team to follow the national standards in order to be certified. I don't believe that we will be giving, I certainly hope we won't be giving a dose of TXA to a downed officer, but it is part of the national standards. So I just need to figure out, is this something, I mean, potentially approaching something from the tactical medicine standpoint to get a regional guideline in place, and that could then in future be used as a protocol in the collaboratives, might be a way of developing TXA as a treatment option. But it's also it's a bit of a headache and a lot of work if at the end of the day it's not going to go anywhere. We don't have any tactical medicine protocol, to be honest with you, in our region.
Jamie, as their medical director as a separate agency, I think you've got the right to go ahead, even without the REMAC's approval, to do that. You know,
okay.
if you'd like to develop it and bring it forth to the REMAC for utilization, maybe as an addition to the collaborative, that would be okay too. I'd love to see your protocol when you come up with it. We've just added it to the SCT protocols because it is, again, as you said, being used throughout the world, and we may be seeing patients being transported with TXA. So,
okay.
My personal opinion is it's cheap. It has a limited downside, and it may be helpful.
Okay, I'll develop it, and maybe I have a medic that's very interested in developing a more formal tactical medicine set of guidelines, which we may want to develop as a region.
Look forward to seeing it. Thank you. Any other new business that anyone would like to bring forth? If no other new business, a motion to adjourn.
Jack, I had requested, John, that I have 5 minutes of executive session at the conclusion of the meeting to speak to the medical directors or the voting members of REMAC.
Okay. John, do we need to technically vote on that? Can we just do it?
Just make a motion to going to executive session. You can conclude the meeting and make a motion to go into executive session.
Back to Surratt.
Make that motion.
Anyone opposed? All right, we have a motion to adjourn the REMAC meeting, go into executive session. So I thank everyone who has been in attendance. I urge you to be cautious about COVID and pass it along to all of your colleagues. And I hope you all stay well, and we'll see you again in several weeks for voting members and in a month or so for the regular group. Again, stay well and thank you.